Welcome, guys, to this Harrison-based module discussion where we are going to discuss today about renal tubular acidosis, a very important topic. This topic is very important for whichever exam you are facing, whether NEET-PG or NEET-SS or FMGE. One or two questions is expected from it. So it will be a short video and it will help you completely revise the topic. So what is it actually? This is a condition when there is buildup of acid in blood. And when there is buildup of acid in the blood, this toxic element, it will result into different sort of symptoms. Now, this acid buildup, you might know, can be divided into two types based on the anion gap, either due to high anion gap metabolic acidosis or normal anion gap metabolic acidosis. Normal anion gap. Usually, when these unmeasured anions or unmeasured products are not there, apart from the sodium, potassium chloride, and bicarbonate, when these unmeasured products are more, there is chances of high anion gap metabolic acidosis, which can be seen in uremia, which can be seen in lactic acidosis or sepsis. But in renal tubular acidosis, this acid buildup is usually normal anion gap in most of the cases. Why so? Because it's not due to the unmeasured anions or cation, but due to the measured anion and cation defect. What are the measured anion cations? Measured one are or bicarbonate. Okay, so this is a normal anion gap metabolic acidosis where the defect lies at the level of the renal tubule. So what is the defect at the level of the renal tubule? Defect at the renal tubule is either defect in acidification, which is the main function of it, or there is loss of bicarbonate. All right. So this is gist of RTA or renal tubular acidosis that you need to know. Now, one very important thing that you should consider is that this is a defective renal acid base regulation case and normal anion gap metabolic acidosis is seen, and usually the kidney function remains relatively preserved. So creatinine and urea usually remains normal in these cases. Okay, so kidney function is preserved. All right. Okay. So coming to this again, based on the location of which part of the tubule is involved, we can classify this renal tubular acidosis, or based on which channel or pathway is involved, we can classify this renal tubular acidosis. Now, if there is wastage of bicarbonate, it is usually defect light more proximally at the level of the proximal convoluted tubule. We give the name proximal RTA. If it is defect in acid secretion or H plus ion secretion, defect is usually at the level of the distal most part. Okay, defect is at the level of the distal most part, and we give it name the distal RTA or distal renal tubular acidosis. Okay, so distal RTA or DRTA is type 1 RTA, renal tubular acidosis, and it is due to defect in H plus secretion. Okay, so there is excessive H plus secretion in the blood, resulting into acidosis. Whereas proximal RTA, renal tubular acidosis, or PRTA, is type 2 RTA, whereas there is loss of bicarbonate or bicarbonate wasting. So there is loss of base. That's why in calculation, acid level increases in the blood. So there is no true rise in acid level, but due to loss of excessive bicarbonate wastage, there is acidosis. Okay. Now there is one special kind known as type 4 RTA. Here the defect lies actually at the level of aldosterone and renin. So defect lies at the level of RAS axis, which result into renal tubular acidosis. This type of renal tubular acidosis is associated with hyperkalemia or increase in the potassium level. Okay. Now we'll come into detail more again. So first of all, let's look how to approach before moving into the MCQ. So first thing is that when there is normal anion gap metabolic acidosis, first thing just rule out the usual causes. Usual causes are GI losses or sodium chloride iatrogenic infusion. How do you know that? You check for urine anion gap. If urine anion gap is negative, so this is most likely case of GI loss or excessive acid intake or excessive sodium chloride infusion. If urine chloride is positive, urine anion gap is positive, it is the case when you need to consider for renal tubular acidosis. What are the parameters that need to be checked? Parameter that need to be checked are urine pH, serum potassium, and bicarbonate loading. Usually what we check is serum potassium and bicarbonate. Why so? If serum potassium is more than 5.5, invariably it is nothing but type 4 RTA. Okay, due to defect at the level of RAS axis. All right. Okay. Now, if potassium is less than 5.5, it can be type 1 or type 2. Now, what happens in type 1 is that type 1 pH level remains more than 5.5, whereas in case of type 2, pH level remains less than 5.5. So, from here, you can see in proximal RTA, which we also call to be a type type 2 RTA. In proximal RTA, which also calls to be type 2 RTA, here urine pH is less than 5.5 and serum potassium remains low. Similarly, forget this part. In classic type 1 RTA or distal RTA, potassium is low but urine pH is more than 5.5. Okay. So from this, we can identify where is the defect, check for the proximal tubular defect, proximal renal tubular acidosis, and distal RTA for the distal tubular defect. Remember, when there is a defect in distal tubule or there is classic type 1 ITA, there is high chance of calcium deposition resulting into nephrocalcinations. Okay, so there is high chances of hypercalciuria and patient may present with decrease in calcium level too. Okay. Okay, now type 4 RTA, when pH is less than 5.3, potassium is high. You check for type 4 RTA, check for renal parenchymal disease, assay plasma renin activity, and serum aldosterone level. Perform TTKG. Why TTKG? TTKG needs to be performed to check for the source of increase in potassium level. All right. Okay. So this is the chart from Brenner's that you need to know. Basic, simple thing again. What we are discussing here, RTA, suspected case of RTA. So here this is to just for check for proximal tubular function. What are the proximal tubular function? You see, proximal tubules is associated with excretion and reabsorption of substance like glucose, amino acid, or bicarbonate. So function of proximal tubule is nothing but to detect the fractional excretion of the substance. So what substance we are looking at? We are looking at glucose, then we're looking at amino acid, we're looking at bicarbonate, all of this fractional excretion. Okay. Now here the meantime I want to discuss one thing here along with you all. So there is a disease which is given by the name of Fanconi syndrome. In Fanconi syndrome, defect lies at the level of the proximal tubule. So, Fanconi syndrome associated renal tubular acidosis is usually proximal renal tubular acidosis. Okay. So, how is tubular reabsorption checked? Proximal tubular reabsorption checked. There are some injury marker. What are these injury marker that you need to know? Injury marker are KIM1, which is also given by the name kidney injury molecule 1, and there is NGAL, which is neutrophil gelatinase associated lipocalin. These protein are used to check for tubular injury. These are specialized biomarker actually which are currently in study. Okay, so we know how to approach, we know how to consider and how to consider that it is renal tubular acidosis or not. Okay, now let's move into the first question of the day. Okay, so as you can see here, so just correct it. Okay. So here as you can see a middle-aged woman with known Jorgen syndrome or hypergammaglobulinemia present with hypokalemia, hyperkalemia, normal and gap metabolic acidosis. So what is being said here in this question? Here it is said the patient is of known Jorgen syndrome. Okay. First point. Second, there is gamma globulin level is low, high, which is a feature of Jogan syndrome. Then electoral abnormality for our concern is hypokalemia, first thing. So what is already ruled out? It is nothing but it is not type 4 artery. Okay. It is not type 4 artery. We know this very basic at the very onset. Okay. Then there is increase in chloride level and normal anion gap metabolic acidosis. And this is the condition when you consider to evaluate for renal tubular acidosis. Now she is being treated with steroids for tubular interstitial nephritis. Okay, lab value is given bicarbonate is 16, which is low. EGFR is on lower range. Which laboratory test is most appropriate to order next to confirm the diagnosis? So what to know from here is that this case is a Jogan syndrome. Jogan syndrome, if you know, is usually a classic cause of distal renal tubular acidosis. Okay, and this hypokalemia and everything is fitting towards more of a distal ITA, but we'll come into it. Their serum bicarbonate is low, EGFR is preserved, more or less preserved or in the lower range in the 55. So it is something not of a chronic kidney disease of a pattern, more of a tubular defect because of which bicarbonate is low. So this low bicarbonate is not due to chronic kidney disease, but you know it is due to some of a tubular defect. Okay. So next step is to check for urine anion gap. Any case. Okay. Check for urine anion gap or urine pH. Why so? Based on the urine pH, we differentiate between type 1 type 1 and type 2 ITA. How do you do so? How do you do so? Type 1 ITA, also known as distal ITA, which is usually expected in case of Jogan syndrome and so type 1. Type 1 ITA is also known as distal ITA, and this distal ITA is expected in case of Jogan syndrome. Type 2 ITA is known as proximal ITA, and it is usually not seen. So what is the defect in proximal ITA? In proximal ITA, defect is there is loss of bicarbonate in urine. So there is more of a bicarbonate in urine, and urine pH stays lower, less than 5.5 here. And in case of distal ITA, there is acidification defect in H plus secretion. Here, urine pH stays more than 5.5. So, how do you evaluate this case, whether it is a distal ITA or not, which is expected because we are thinking that to be Jogan syndrome. So, urine pH should be more than 5.5. So, our next step is urine analysis. Okay. All right. Now, coming to the next question. Which type of RTA is most commonly associated with diabetes mellitus? Okay, so this is a nice question. Now, look, um, in diabetes mellitus, there is in classically in the long-standing diabetes mellitus, there is autonomic neuropathy. So when there is autonomic neuropathy, it is expected to affect on RAS axis. So if RAS axis is expected to be changed or affected, in such cases, what will happen? Renin will go low, aldosterone will go low, and which will affect into increase in the potassium level in the blood, and there will be normal anion gap metabolic acidosis. Here, kidney can acidify urine. So, kidney acidification mechanism is absolutely fine, but ammonium excretion is impaired. That's why there is effect. So, urine pH becomes less than 5.5 because acidification parameter is 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 absolutely normal in case of type 4 IDA. Okay, all right. So this in renal tubular acidosis most commonly associated one is type 4 IDA. All right. Okay. Now coming to the next question. So here, a 34-year-old man on long-term HIV, pre-exposure prophylaxis, tenofovir desproximal fumarate. Okay, so the patient is on tenofovir and it is on long-term. Present in dark-colored urine. His blood pressure and heart rate are normal. Okay, so it suggests RAS axis is not affected actually. Laboratory evaluation reveals sodium to be of normal range. Chloride is 112. potassium is 3.1, which is low, bicarbonate is low, there is acidosis, creatinine is little bit higher, urine pH is less than 5. Okay, so how do we evaluate this case? So you see, finding here low bicarbonate, low potassium, and low urine pH. So low urine pH means kidney can acidify. So defect is not distally, it is defect in the bicarbonate level or type 4 RTA level. So it is more of a proximal RTA or type 2 RTA. Okay, so this is a type 2 renal tubular acidosis or proximal RTA. Okay, so there is no hyperkalemia. Hyperkalemia should be in type 4 RTA. Okay, so why does it happening here? Because this tenofovir is well known to cause proximal tubular injury. Actually, due to this proximal tubular injury, there is sometimes acute interstitial nephritis like pattern, and that's why creatinine jumps up. Okay, so but this is not directly linked to it AKI, this electrolyte imbalance. There's more of a link to the proximal tubular injury resulting into Fanconi like dysfunction, which causes proximal renal tubular acidosis and such electrolyte imbalance. And this due to proximal tubular injury, later it can be acute interstitial nephritis and acute kidney injury for which creatinine jumps up. Okay. Now coming to the next question. A 32-year-old woman present with weakness, BP is 100 by 60, normal and non metabolic acidosis. So BP is again on the normal side. So it is not going for type 4 ITA. Alright. Now left panel shows a normal and metabolic acidosis. Urine pH is 8.5. So it is more. Urine pH is more. So what does it mean? It means acidification is impaired. So acidification is impaired only when there is distal ITA. So it is nothing but a case of distal ITA. Okay. So it is a case of distal ITA. Option A is the correct answer. Okay. So we have looked into how to evaluate the cases and how to consider which kind of ITA. From this, we will go into what are the etiologies. Okay. Now, one thing is that you should know from here is how to manage. Look, type 1 and type 2 arteria are treated with oral bicarbonate because these are easily treatable. Okay, so type 1 and type 2 are treated with oral sodium bicarbonate, and it is usually given lower dose in type 1, and in type 2 it should be given to a little bit of more dose, this oral sodium bicarbonate. Now it is titrated according to the metabolic acidosis level. Okay, now, potassium supplementation is required when the patient is hypokalemic, not in the most cases. Usually, type 1 arteria or distal arteria may present with hypokalemia more often. Okay. Now, if there is mineralocorticoid deficiency, in such cases, fluorocortisone can be given to the patient. Okay. Now, in chronic treatment, as in case of type 2 artery, we need to monitor the potassium level. We need to check for hyperkalemia. We need to monitor for bone diseases in case of type 2 RTA. Why so? Because there is chances of hypocalcemia related injuries, and we need to check for nephrolithiasis and nephrocalcinosis in case of type 1 RTA. Okay, so that's all you need to know about non-tubular acidosis. In the next module, we will cover another important topic regarding this Harrison based topic, and we will discuss about MCQs.